So our second speaker is Professor Trish Greenhalgh, friend and colleague of Alison Kitson, who may well have played the friendship card there, I'm not sure. But we are really honoured to have Trish speaking at our conference. She's a professor at the University of Oxford and co-director of the Interdisciplinary Research in Health Sciences Unit. She trained as a GP and is an internationally recognised academic in primary healthcare. She accepted an OBE in 2001 for services to evidence-based medical care. She also has a very broad reach, 100,000 followers on Twitter. Can you imagine dealing with that? And I might also add that she has experienced breast cancer and has co-authored a best-selling book on that topic. Her talk is titled Doing COVID-19 Science in a Post-Truth World.
Hello, today I'm going to talk to you about my work doing COVID-19 science in a post-truth world, and acknowledging my funders, which you can see on the slide. It's been a pretty strange few months, hasn't it? And there are different kinds of science that have played out in the COVID pandemic. I'm just showing you two very contrasting kinds of science here. On the left, dexamethasone for severely ill patients with COVID-19. And as I'm sure you all know, randomized controlled trials there were pretty straightforward, and they quickly produced definitive evidence that this is a very good drug in some subgroups of patients. But then there's the question of masks and face coverings for preventing the spread of COVID-19. Now, that's all much more complex and contested. At first, there really wasn't any direct evidence. We were taking evidence from other diseases, for example, but then lots of studies started to appear. But those studies were contested. They were ignored, actually, by a lot of scientists and policymakers for quite a long time, and indeed are still ignored and contested by some. Let's think a little bit about evidence-based medicine, which I'm going to choose to define for today's talk as nice, clean experiments on well-defined population samples. And of course, the dexamethasone versus placebo for severely unwell patients with acute COVID was a great example of this. It fitted the EBM paradigm really well. And it fitted this hierarchy of evidence, which you've probably heard of. Don't worry if you haven't, because the idea is that there is a methodological hierarchy, that certain methods are better than other methods. And right at the top, the red bit, that's where they want you to be, is systematic reviews and randomized controlled trials. And you can see you could go down through the rainbow with different kinds of study, each of which is considered to be a little bit worse than the one above. Right at the bottom, you've got something called case-based reasoning or expert opinion. Whatever you do, don't ask an expert. Interesting, isn't it? Now, what happened with masks? Well, one of the things that happened with masks was that the mask studies that were ignored were considered too far down evidence-based medicine's hierarchy of evidence. These sneeze videos, the idea that you could video a sneeze and light up the droplets and then get your paper into the New England Journal of Medicine, just didn't fit comfortably with that hierarchy of evidence. Where was the randomized trial? Why was this almost anecdotal study on tiny numbers of people, perhaps only one person got to sneeze? And then the choir story. Do you remember that choir story that came out about, I think it was March, it came out, of 60 people that went to choir practice, and about 52 of them ended up with SARS-CoV-2 infection, and 2 of them died. It was a story about a choir practice. Nobody was randomized. You know, it didn't start off as a piece of science. It was a case study. So despite the fact that its altmetric score down in the bottom right was absolutely huge, it was one of the most tweeted about stories ever, this didn't seem like science to some people. Well, back in March, I and some colleagues wrote a paper. It was published in the first week of April in the British Medical Journal about face masks. And we argued for the precautionary principle. We said, look, this choir practice is really quite interesting. These sneeze videos are really quite interesting. We can't prove it yet, but the harms are likely to be small, but the benefits could be absolutely huge if, as we think, as the evidence is pointing, if the virus is airborne, this could save tens, hundreds of thousands of lives. Precautionary principle, let's act before we have definitive evidence. Well, some people didn't like that. A lot of people set up websites against the idea of public masking. It really didn't fit in with people's idea of freedom. But one or two people set up websites against me, against my work. So the first one here described me as leading the successful charge to make face masks mandatory. So it's my fault that they'd become mandatory. But the thing that they were most upset about on this top website was that I was absolutely sure that I was right, that I'd written in a very kind of forthright and confident tone. Funnily enough, there was another website that was almost saying the opposite. I mean, he still described my paper as a nonsense paper, and his nickname for me is the milk curdler. I don't know why. But his problem with the same piece of work was that it was larded with may this and it seems likely that and other such what he called turgid prose. In other words, what this person's problem with my work was that I wasn't sure enough that I was right. I was too circumspect. Okay, so this sort of thing was happening quite a lot. Well, meanwhile, there were developing two camps of scientists, and I'm going to slightly caricature, and I've only got 15 minutes, so you have to dig more deeply into this to get the nuances. But broadly speaking, two open letters to the chief medical officers of England, Wales, Scotland, and Northern Ireland were sent on the same day. The first one on the left was led by my colleague in Oxford, Carl Hennigan, Carol Sekur is a professor of cancer medicine, and Sunita Gupta, who's a professor of something called theoretical epidemiology at Oxford. And there are a number of other signatories on this, but the argument was that COVID-19 really isn't all that bad, especially for people who are healthy and under 60. That the evidence base for it interfering with people's lives is very weak, and that the economy should be prioritised over further lockdown. Now, that set of ideas fed into another declaration, which got a lot more publicity a few weeks later, called the Great Barrington Declaration, which you may have heard of. And it was published with a great ceremony, actually, on an American website. And the argument was, look, shield people who are vulnerable. Keep them at home in order that the non-vulnerable will be able to enjoy their freedoms. Now, this, of course, linked to a libertarian agenda, to an agenda of getting the economy going and not worrying too much about people who were so-called vulnerable, because actually they should be locked away, for their own good. Now, I didn't think too much of that, so when I heard it was coming out, I quickly put together another group of scientists, various people. There's KK Cheng up there, and there's also Devi Sridhar and lots of others. And we said, well, hang on a minute, this is a serious and sometimes deadly condition, particularly for ethnic minorities, the older people, people with pre-existing conditions, and it also disproportionately affects the poor. The best way to save the economy, we said, is to address public health. We simply cannot have a situation where we're dividing effectively into the haves and have-nots and saying, you guys can get on with your lives, because actually, as a society, we are a single society and we're all going to need to make compromises. And a few weeks later, this set of ideas was turned into another widely publicised memorandum called the Jon Snow Memorandum, which said segmentation and shielding policies are unethical. They're also practically impossible, and they are not scientifically evidence-based. Now, the British Medical Journal ran a news story saying experts divide into two camps of action, shielding versus blanket policies. And we were pitted against each other. And in some ways, the story became the fact that we were arguing with each other. There were also some investigative journalists involved who very directly accused the signatories of, particularly that first letter to the CMOs, of having right-wing lobbying links, that this was, quote, fringe pseudoscience and co-drafted by a government advisor who had downplayed the COVID-19 death toll. And this person claimed that he was not able to find a single peer-reviewed study of one of the leading professors about COVID-19 in the scientific literature. So far from being leading scientists who were doing what scientists should do and publish peer-reviewed papers, they were actually perhaps resting on the reputations of the institutions that employed them. So that's what he was claiming. Now let's have a look at this from a kind of critical social science perspective. Martin McKee and colleagues published this paper in the International Journal of Health Policy and Management, asking the question as to whether populist leaders are creating the conditions for the spread of COVID-19. And they systematically use political science concepts and evidence to argue that the libertarian right is indeed anti-masks, anti-lockdown, pro-segmentation and pro-herd immunity. So this package of so-called science goes with the libertarian right. And another paper, which I encourage you to get hold of, is beautifully written by Jason Harsin, called Toxic White Masculinity, Post-Truth Politics and the COVID-19 Infodemic. And what he says there is the proponents of this libertarian right agenda tend, although they are not always, they tend to be white and male, they tend to be very aggressively confident and hierarchical, and dismissive of so-called female traits, such as emotionality, such as power sharing, and also that trait that was illustrated earlier in some of my work, that sort of circumspection and wondering this and wondering that and not being 100% sure, but saying, look, I'm still uncertain about the evidence. You will know the term post-truth. It's defined as relating to or denoting circumstances in which objective facts are less influential in shaping public opinion than appeals to emotion and personal belief. And Hannah Arendt, who was a philosopher writing around the time of the Second World War, didn't know the term post-truth. It hadn't been invented in her time, but she certainly wrote about it. And she described, if you just read the red text, under the pretext of upholding old truths, this kind of approach degrades all truth to meaningless triviality. And so we get a combination of quasi-scientific language, cherry-picked pieces of data, perhaps some numbers, figures, along with ideological statements about what should happen rather than what's been measured. So let me summarise what was happening in the UK in the later months of 2020. We had COVID-19, we had research going on that progressed at a dizzying pace. Too little knowledge quickly became too much. Facts were quickly contested and became saturated with ideology. Uncertainty became a weapon that started to be used tactically by interest groups. And scientists, their flawed assumptions, their political allegiances, their interpersonal rivalries became part of the story. So what do we do in this very, very toxic environment? Because the kind of things that we were arguing and are arguing for in the Jon Snow Memorandum are things that I care about deeply. They're about social justice. They're about supporting the poor, the vulnerable in society, in addition to all the stuff about science. My science is driven by a commitment to those issues. And of course, I'm now being attacked by people who have a different view about politics and ideology. So what do? I've got 4 approaches. The first is reflexivity. This is a picture of the River Thames, not far from my house. It's a picture of the little place where I go every morning, very early, to sit and reflect for an hour or so. It doesn't always look as nice as that. Sometimes it's raining. Most times I swim, sometimes I don't. I just sit there and I get my head sorted out and remember what I'm doing and why I'm doing it. I almost never miss that. Secondly, and not quite so pleasant, is painful engagement. Unless I know what people are saying about me and about my work, I cannot act in the most appropriate way. I don't have to read everything that people are saying about me, but I do have to get the gist of it. So I have to engage, however painfully, with what's going on. Thirdly, epistemological labour. This hierarchy of evidence, as I hope I've demonstrated, does not apply in all circumstances. With masks, for example, we now have fluid dynamics. As I've shown you, we had case studies of super spreader events, etc., etc. That is good science. We don't need randomized controlled trials in every circumstance. We needed them with dexamethasone. So we need to do work to challenge this very rigid and very pervasive and overused hierarchy of evidence. And I do publish a lot of papers challenging that hierarchy. And finally, deconstruction. Because as I've said, and as Hannah Arendt very powerfully argued, scientific half-truths, cherry-picked data very often gets mixed up with ideology in these grand statements. There is a task of deconstruction. And one of the things we have to do is get our heads into those declarations, pull them out and say, look, there's 4 things going on here. There's orange, blue, green and yellow, and we're now going to address those 4 things. This is basically what we did in the Jon Snow Memorandum. So those 4 approaches to surviving, and not just surviving, but continuing to make progress in this post-truth environment. Here's some pictures of some of the papers that I've written. I call all these forms of epistemological labour. We're really looking and writing about the links between knowledge and power and influence in science and policy making. So thank you for your attention. Enjoy the rest of your wonderful conference, and I'm hoping to be around live to answer some questions. Okay, well, thanks for sending some questions. You've asked about how we got going so quickly with the rapid reviews that were helping with the COVID pandemic. Look, I think the one thing that we had that many groups didn't have was an administrative infrastructure. And anyone who's done a systematic review, particularly a rapid review, will know that there's quite a lot of admin involved. We had people to organise us, people to allocate work, coordinate the exchanging of drafts, all that kind of thing. We had librarians that were ready to hit the ground running. I suppose there's a message here. We had some funding for that infrastructure from the National Institute for Health Research in the UK. And it's a really good idea to fund research infrastructure, which can then allow you to hit the ground running when a crisis happens. Completely different question you've asked about risk aversion in clinicians. Do you know what? I don't think clinicians are risk averse. I think the reason why clinicians are often reluctant to take on new technologies is not because they are anti-technology, not because they're Luddites, but because they are driven by professional standards of excellence. And whether you trained as a doctor, a nurse, a midwife, a physio, whatever, what drives your decision-making is the question, what is best for this patient? It's a sort of Aristotelian ethical question. What's the best thing I can do right now for this patient? And the trouble with technologies is that they may threaten, or they may appear to threaten, those professional standards of excellence. For example, the standard that says we must keep confidentiality. It means that sharing data goes against our instincts as clinicians. The idea of assessing patients remotely, for example, by video or even phone calls, goes against the standard of excellence that says see the patient properly, put your hands on them, examine them. So I think the way to overcome this is to stop depicting clinicians as Luddites and start to listen to their professional concerns. And then you get into a co-designed dialogue where the technologies are often amended, and also the work processes and practices are amended in parallel with tweaking the technology. And then you can have quite a lot of fun. You can actually work with your clinicians rather than sort of trying to drag them like a stubborn animal that doesn't want to go somewhere. You've also asked me about what I would call digital inequalities, that the huge benefits of health technologies are not evenly distributed, and people, for example, who are poor, who don't have broadband, who are not well housed, who just don't spend their money on the latest gadgets for whatever reason, be they very elderly or whatever it might be, they miss out on some of those opportunities. There is no easy answer to this. The standard reply is, well, of course, if 3/4 of the population use these wonderful technologies, we can then put more work into meeting the needs of the others through other means. But of course, that it rests on the assumption that those using the new technologies are actually doing something that's more efficient, that's going to save time and money. In fact, you often find that the attention goes into making the technologies work, and people are very distracted from addressing the needs of the people who are not in that system. So yeah, we have to keep working really hard. I have to say, one of the best examples of the use of technology to reduce inequalities has been across the continent of Africa, where they've used these very basic cell phones, not the smartphones, just your old Nokia phones, and they've used text messaging for patient education, for keeping in touch with patients, and for monitoring various chronic diseases. And that has worked extremely well, because what they did was they asked, well, what technologies do people already have, and how can we harness the potential of those technologies, rather than to try and get people to use and buy a technology that they don't understand or they can't afford. So I think working with rather than against people is one thing. But yeah, there is no easy answer. And finally, on social media, look, I get it if you don't like social media at all. I really do get that. But I would say, if you don't learn to ride the tiger of social media, it's going to ride you. I put a lot of work, a lot of time into my chosen social media platform, which is Twitter. I deliberately spend time trying to find things that my followers might like. I post links to papers and that kind of thing. I put up nice pictures and that kind of thing. What that means is that people follow me because they like what I post. And it then means that if I want them to do something for me, for example, if I write a paper, I want other people to disseminate it, or I'm advertising a job, I want people to apply for the job, it's actually quite quick. So I would say overall, Twitter saves me time. The other thing is, if people are being abusive, if people are being rude, nasty, I block them. And if I don't want to hear about them, like certain politicians' names, I mute them. So you need to learn the functionality of your social media platform, but then, yeah, ride that tiger. See where it gets you. Thanks a lot for listening, and enjoy the rest of the conference.